Thank you for joining us on the HSS podcast with me, Lenias Hwenda, where we talk about health in Africa. This is the Neglected Tropical Disease podcast series, on which we're talking about a group of diseases that include parasitic, viral, and bacterial infections that cause substantial and devastating illness, as well as economic challenges in some of the most disadvantaged communities around the world. Several of these diseases can be controlled or eliminated through existing straightforward community-level interventions, including mass drug administrations of preventive medicines and making sure that people have clean, safe water and adequate sanitation. These diseases are not rare. Globally, they affect more than 1.7 billion people. They don't just destroy lives. They prevent people from reaching their full potential and limit economic productivity, which in itself traps families in vicious cycles of poverty. The health impact of neglected tropical diseases are both obvious and devastating. They can disable, disfigure, and if left untreated, they can even kill. To change lives and improve economic productivity, more investment is needed to control them in order to achieve elimination. But achieving elimination requires greater commitment from leaders in government, in the industry, and in communities to do what it takes to eliminate neglected tropical diseases. My guest today is Dr. Pauline Mwinzi, a technical officer for neglected tropical diseases at the World Health Organization Regional Office for Africa in Congo-Brazzaville. There are about 7 parasitic worms that cause neglected tropical diseases, and of these, soil-transmitted helminthiasis and schistosomiasis are the most widespread neglected tropical diseases in Africa, where they cause significant loss of years of life, productive life, due to disability. In fact, each year, 2.1 million life years are lost to only these 2 diseases. Dr. Mwinzi is going to be talking to us about schistosomiasis, which is also called bilharzia. Dr. Mwinzi, welcome to the HSS podcast. Thank you for coming on to Let's Talk About Health in Africa.
Thank you, Lenias, for having me.
Wonderful, wonderful. So you are working on the expanded special project for elimination of neglected tropical diseases, which I understand is a project that is running under the World Health Organization. What can you tell us about ESPEN as a program and its mission and what you're trying to achieve with it?
Yeah, you're right. ESPEN is part of the WHO Regional Office for Africa, and it was established by our director in 2016, that's Dr. Mwinzi. And it's a public-private partnership. So it was established in the spirit of partnership between WHO, the member states, and the broader NTD community of partners. It was launched with a very ambitious goal to accelerate progress in the fight against the 5 preventive chemotherapy neglected diseases that are the most prevalent in Africa, as you already mentioned, starting with schistosomiasis, soil-transmitted helminthiasis, onchocerciasis, lymphatic filariasis, and trachoma. So we are a core team of disease-specific experts here in WHO office in Brazzaville, and it includes a very strong data team because elimination of these diseases requires data and a strong evidence base. And then we have presence throughout Africa in all our WHO country offices in every country, represented by an expert, a professional officer for tropical and vector-borne diseases. And so ESPEN is designed to support the governments as they aim to strengthen their NTD elimination programs, to take the additional step towards sustainability and plan for the integration of NTD control, elimination, treatment, prevention into their health systems. And just lastly on this, the operational and other support that is provided to governments, it's on their requests. we work directly with the leaderships in this government, the ministries, and other government staff to scale the impact of NTD elimination efforts. And most importantly, or very importantly, ASPEN provides as well platforms through which the governments can submit requests for medicines that are processed through WHO, as well as collecting, sharing, and accessing data and building the personal capacity of staff in NTD programs in countries.
Yes, sounds like your hands are quite full. You're trying to do quite a lot of things, training the human resources with giving them the skills they need to be able to help you to tackle those, bringing public-private partners to work together with communities, with leaders in government to eliminate these diseases. I think that's a really important thing, in particular because these diseases are affecting some of the most vulnerable people in our communities. Now, what is your sort of hopes for the next 5 years? What do you hope to achieve with ASPEN in the next 5 to 10 years?
In the next 5 to 10 years, we are guided by the NTD roadmap 2030, and we have placed the targets there. Most notably, we are expecting that a good number of countries in the region will achieve the milestone of elimination as a public health problem. For schistosomiasis and for many of these diseases, which means the diseases would no longer be requiring mass preventive chemotherapy in, at national levels, in all endemic areas, all part of those areas. And therefore, this is what we'll be working towards, making sure that the strategies that we have are in place in these countries for as many as can make it by 2025, by 2030, to eliminate these diseases as public health problems.
Yes, no, that's wonderful. But what will it take to achieve this? Because we, in our health systems across many countries on the continent, we are facing so many competing priorities and challenges, human resource shortages, and so forth. So the challenges are many. What will it take for you to be able to achieve that goal and the goal of elimination?
There are key critical actions that we've also highlighted in the NTD roadmap that specifically, for example, in the area where I work for schistosomiasis, are going to be very important for countries to take, to move towards these milestones. And these include implementing effective interventions, including extending the preventive chemotherapy that I just talked about to all populations in need, because there has been gaps there, ensuring access to the necessary medicines, because there have been gaps in people that need the medicines, accessing the medicines, implementing targeted snail control. And snail is the intermediate host for schistosomiasis, for example, and with updated the guidelines that we have shared to continue macro mapping of the disease in order to have better targeted interventions where they are most needed. And then other actions will include developing diagnostic tests that are appropriate in the settings where they are needed, including standardized point of care diagnostics, and developing new interventions, including alternatives to the medicines that we have now, to praziquantel, and also coming up with methods for snail control where this will be necessary. And then I could add that we'll need to create effective cross-sectoral governance mechanisms to coordinate with the WASH sector, that includes sanitation and safe water provision, as well as vector control, animal health, because these diseases, especially bilharzia, that is schistosomiasis, are zoonotic and involve other animals. And therefore, actions such as environment management and working with the people in these key sectors will be critical. And lastly, I could add that we will need to ensure sufficient resources. And here we have to talk about our own domestic financing from our own governments for access to interventions that is, as I said, mass drug administration for both children and adults. We do not have enough resources, which for now we've relied on outside support in many of the cases. And as I mentioned as well, development of new tools and then strengthening the healthcare capacity.
Yes, I think the points you make about innovation for diagnostics that are more sensitive and fit for purpose and treatments as well. I guess that's where the neglect, some of the biggest neglect has been, the fact that we don't have a choice of tools that can help us to tackle these diseases, in all their manifestations, to help communities get ahead. Now, we will delve a little bit deeper into treatment and diagnosis a little bit later, but first, talk to me about, what is schistosomiasis? How big is the burden of this disease on the African continent?
Thank you. Schistosomiasis, which is also known as bilharzia, is a disease that is caused by 6 species of a class of worms called the trematodes. And these species include, to use their scientific names, Schistosoma guineensis, Schistosoma hematobium, Schistosoma intercalatum, Schistosoma japonicum, Schistosoma manzoni, and Schistosoma mekongai. So the most predominant causes of the disease, and especially here in Africa, is the Schistosoma hematobium that causes urogenital form of the disease, and Schistosoma manzoni that causes intestinal form of the disease. So just these parasites that I've just named are the species of the worm that get into the human body and cause the disease. And the infection occurs when the schistosomes, or these parasites, are transmitted during contact with fresh water, which is contaminated with human waste, with human excreta containing the eggs of these parasites. And a snail host must be present in that fresh water to allow the parasite to complete the life cycle. So it comes from us contaminating water bodies, and then this gets into the snails and eventually back to us when we are in contact with the water. And so in terms of the burden, globally, 78 countries and territories that are endemic throughout the world, 44 of these are in Africa. So the significant burden for these diseases in Africa, 91% of the burden is in Africa. But only 51 of these countries that are endemic are in need of mass chemotherapy, that we also call preventive chemotherapy. And 41 of these are in the Africa region. That means the disease burden in these countries that require the mass chemotherapy in affected populations is of public health significance. Areas have higher than 10% prevalence of the disease. At the moment, we have over 240 million people requiring preventive chemotherapy in 2022, and over 216 million of these are in Africa. So it is a huge burden. It's highest in school-age children, where over 130 million are affected, and then about 100 or so million adults, who would mostly be people in occupational water contact, fishermen and other types of water contact for which people engage in.
Yes,
so and burden indeed.
It sounds like a really big burden, and it's really tough that it affects, it's transmitted through water bodies. I grew up in Zimbabwe, and I remember as a kid, when you're in the village, of course, you want to splash around in the water puddles, and that's exactly where the risk is. So the environmental measures presumably would be actually very, very important in your goal towards elimination. And so do you work with the One Health approach with the environmental sort of departments, or how is that sort of built into your approach as WHO, predominantly dealing with treatment issues and prevention?
This is what we have tried to encourage, and we're encouraging now. We have placed it very strongly in the NTD roadmap 2030. It hasn't been very strong in the past that we've given it a One Health approach, but we want to do so now, especially because we're seeing a lot of infection with domestic animals as well in some settings, and would be afraid of the kind of bridging between the species. So yes, a One Health approach, especially in areas where domestic animals are involved for schistosomiasis. But most importantly, the other line sectors, the ones in water engineering. How safe are the water bodies? Do we have sanitation around those water bodies where there is immense water contact activities? And how aware are the communities in those areas? So yes, these are the strategies that the national programs engage in the local areas, and that we support, especially the awareness among the communities and improvement of sanitation in areas where there is water contact.
Yes, no, very interesting. So which are the highest burden countries that are especially on our continent, and how well or are they dealing with the control measures in your efforts to help them to make progress towards elimination?
Well, sure. I would say that while these high burden countries have actually made tremendous progress, as well as all of the rest of the countries. I talked about 41 that need preventive chemotherapy. And of course, the challenge is bigger for these high burden countries like Nigeria, Ethiopia, Tanzania, DRC, where we have huge numbers of people that require interventions. But we have to thank all the partners who have come together in these countries, implementing partners and donor partners who have worked with the governments in these countries to make sure that they achieve, and they have achieved by the end of 2020 and by the end of 2021, 100% geographical coverage in all of the endemic countries. So we have up to 29 countries out of the 41 that require PC or rather preventive chemotherapy that are fully scaled up. That means there are interventions in all of the districts that are endemic. And we have only, about 12 countries that are working towards scaling up to all of the endemic areas by the as we start on the roadmap 2021. We, however, have perhaps 2 countries lagging behind for various reasons, and are working on eventually getting started with the mass treatments for the populations that need them in the current year. That include Equatorial Guinea and South Africa, which has done very well for soil transmitted metastasis, but because of still trying to put together its data for schistosomiasis, they had not yet started the mass interventions for schistosomiasis. But notably, we have a number of countries that have been achieving the recommended threshold of 75, reaching 75% of school-age children. Up to 9 countries, by the end of 2021, including Burkina Faso, Burundi, Cameroon, Cote d'Ivoire, Malawi, Mali, Mozambique, Rwanda, and Togo. And so we really want to highly commend these efforts in these countries, and looking forward to seeing many other countries joining these milestones.
Yes, I was actually looking at some of your data. You have been doing beautiful work with the mapping and showing the burden of disease in different parts of the region and what countries are doing. And what I found quite striking, if I remember correctly, I didn't see South Africa was not doing mass drug administration, which I thought was quite striking because the burden seemed quite significant. So my next question is, what really makes the difference? You mentioned three groups of people, of countries, some that are doing very well. I think maybe 29 you said, and some that are sort of working towards scale up and a few that are lagging behind. What is the single biggest factor that differentiates these groups of countries? You mentioned earlier that you need to have countries or governments beginning to contribute finance towards tackling these diseases. Would it be finance? What is the difference between the different countries and the progress that they are making?
Different challenges in different countries. For example, a number of countries that are still trying to scale up to some areas where there might be, civil conflicts, and therefore it may be difficult for program managers to go to those areas for security reasons. So we have a few cases like those in the Africa region. But in the case of South Africa, for example, of course, it is also a large country, and they have been mapping, one province after another, looking at the data and building finance case studies for these provinces. And what is going to be impressive with South Africa is, they'll be able to fund their own campaigns when they have all these budgets for the regions in place. And so it's the planning that has taken time, because they're looking to using domestic resources, which is really highly commendable, and we are looking forward towards this. They're already doing the same for the soil-transmitted helminths program. They do not look for outside funding. And therefore, while the implementation of the schistosomiasis mass treatment has delayed, we have big lessons to learn from South Africa, especially domestic resource mobilization and ownership of their NTD programs. So different challenges for different countries, but we then work with the countries based on their specific challenges to overcome those.
Yes, no, I think, I suppose there will be lessons that each one, they can all learn from each other. Some will do certain things better than others. And really, I think the sustainability aspect presumably is one of the most important factors that you want to build into these programs. So, and if countries are self-financing, that goes a long way to make sure that the programs that are being put into effect, implemented on the ground, can actually go well into the future, and that progress can be sustained. Now, before we start talking about treatment in more depth, can you just put it into perspective for us? You say 240 million people affected by this particular challenge on the African continent. What does it mean for individuals, both in terms of quality of life and livelihoods, people being able to earn a living and support their families?
Yes, that's really a good question, because the disease causes quite some morbidity in individuals. It can be quite devastating long term. In the intestinal form of the disease, I said there is intestinal and urogenital form of the disease. The intestinal form of the disease results in diarrhea. Patients would see diarrhea and blood in stool. They would see enlargement of the liver and of the spleen, and a condition called portal hypertension that is common in advanced cases. The urogenital form of the disease is characterized by the presence of blood in the urine. Okay, so you can imagine this is quite traumatizing to children, especially, and to adults as well, who do not know what they are dealing with when they see these kind of symptoms. So it can cause, the individuals can be traumatized and isolate themselves. Then the chronic infection in the urogenital form of the disease can result in fibrosis of the bladder and of the ureter, and can evolve to a condition we call hydronephrosis, and create conditions for bladder cancer. So this disease can lead into very serious consequences, and we've seen this in the communities. The urogenital form of the disease as well, which is characterized by the presence of blood in urine, and can cause fibrosis in the bladder and ureter, can also in women cause what we call female genital schistosomiasis, where women may experience vaginal bleeding, genital pain, and nodules in the vulva. And so this condition, which we only now, really beginning to gain momentum in creating awareness in communities, as devastated women, especially in areas that are endemic for the form of the schistosomiasis caused by Schistosoma hematobium. This chronic manifestation of the disease needs to be urgently addressed and prevented in women. And the primary form of preventing this is, again, treatments. But men, it also affects men. And in men, the urogenital schistosomiasis can induce disease in the seminal vesicles and in the prostate. So really prevention is key, because once these chronic conditions are set in, there is sometimes not much we can do in advanced cases. And so you will find both men and children, or rather children and adults who are affected by this disease will tend to have less energy, they'll tend to be tired all the time, not concentrate very well in school, and adults not be able to work effectively. And we see a lot of improvements in this in communities that are treated, that, children will be more active in school, and adults are able to be active on the work in their daily activities. So yes, a huge burden at the individual level.
Yes, no, and of course, if children are obviously suffering in this way, they miss school and they fall behind, and that affects their future prospects in the labor market and so forth. So you can see how this problem can really spiral into a vicious cycle that can be very difficult to break. And the problem that you mentioned, the female genital schistosomiasis, I only just learned about it late last year, when I was looking into starting this podcast on neglected tropical diseases. At school, we did learn about the life cycle of this worm, but I never knew that it actually affects women in such a brutal way that it does, and with such a high burden as well. So, and the need for it to be integrated in reproductive health care and screening for it, and its links with cervical cancer. So it's really quite incredible how big the problem is actually amongst women. It was an eye-opener for me. Now, let's talk about then prevention and control. I had a conversation with with someone from the Nigerian government talking about polio eradication. And one of the things that really came out of that conversation is the importance of communities owning the interventions that you put into effect and being able to drive that, with community leaders at the forefront of those efforts. So can you talk to us about how you are working with communities, individual communities, to make sure to put into practice these prevention interventions, and whether communities are getting the right kind of support to enable them to own those programs and drive them as leaders within communities?
Yeah, this is a very good question, because in all sectors of public health, you cannot achieve much unless you have the full participation and appreciation of the issues by the people that are affected, the communities. And so ensuring that at the very local communities where the transmission is occurring, people are aware of what is going on there and how they are affected, how they get exposed, and what it means to them, understand the symptoms that they see and what those symptoms are. It is key, because in many cases, the symptoms are not appreciated. That's why we talk about these conditions being neglected. They'll get confused for other more well-known diseases, like malaria and so on. And so working with the communities to understand what it means when they step into water, and how they can make that safer, and how the disease is transmitted. Being able to recognize the snail, because we have very many kinds of snails. Which ones are the intermediate hosts for schistosomiasis, and what it means when you see it in this particular water where you're doing your domestic cures or where you're fishing and so on, is key. And so we have developed a tool that can help our member states, our health professionals at the front line in communities, to work directly with communities and help in this education, for communities to be able to recognize what the risk factors are. And so this risk assessment tool that is very easy to use by frontline health workers, and for education for themselves as well, because we tend to bring the activities from the national level. That has been quite the practice in the past. So you have experts that come from national level, scientists that come to see whether the disease transmission factors are available in particular settings. But the communities can use these tools to be able to identify, recognize these intermediate hosts, and be able to say, yes, we are exposed in this community. And working with them, in this, when they know what the risk factors are, then they're able to participate better in the prevention at those levels, especially when it comes to sanitation. And we have already made a lot of course, progress working with community health workers, and they will continue to be very key in this area. Community health workers have been the foot soldiers on the ground, supporting program managers and health workers in these communities, distributing medicines door to door and providing education. And so we'll want this to continue. We'll want community health workers to be better supported by governments and able to continue with supporting communities, education and treatment as well. They distribute the treatments to communities at the same time.
Yes, no, that's really great to hear, because I think we cannot move forward sustainably without the community leadership for sure that has been demonstrated. So now, in terms of then the interventions that really brings the best improvements in health outcomes. You mentioned that you had now started to look at integrating or taking the One Health approach, where you're looking both at the life cycle in humans and in the environment to see how that can be broken, the chain of transmission and so forth. So can you just talk to me about some of the best combination, or some of the combination of interventions that you are seeing to lead to the best outcomes, especially in the countries that are making a lot of progress?
Yeah, sure. We have had a lot of experience of what is working best in countries for the past decade. And of course, this has helped us to come up with the new schistosomiasis guidelines, which we just disseminated now and are going to be launching on the 15th of February. But in the NTD roadmap as well, we present the core strategic interventions that are necessary for schistosomiasis. The primary one being what I've already largely talked about, preventive chemotherapy, which involves the regular treatment through mass drug administration with praziquantel to the at-risk groups that include preschool age children from 2 years of age, school age children, and communities, especially adults that are in occupations that involve water contact. So that's the primary one. We need to address the infections that people already have, and then be dealing at the same time with the prevention. And here is where, you know, the other strategic interventions come in. The WASH area, for example, ensuring access to safe water. And this goes beyond the NTD program managers because they don't deal with water. So that's why we have to work with the line sectors in the government that deal with water engineering, the ministries of water and so on. And this WASH also involves improved sanitation and management of human waste across communities, as well as educating people about individual hygiene, that is use of toilets and personal hygiene and so on. And then I mentioned the intermediate snail host that is necessary for the life cycle. You know, the parasite goes through the snail before it can get to humans. And so we have a component for vector control that countries also need to implement. And for this, in a very controlled way, we have molluscicides, and these are chemicals that can be used to control snails where we think this is necessary, especially in high transmission areas. And so the same, in the same way, where it is feasible, we can also use physical removal of such snails, or modify the environment such that snails may not breed in those areas, because we know they breed in vegetation along water bodies, you know, on the shorelines of water bodies. And then, yes, we've talked about One Health, and so we have to talk about here also the veterinary public health. Keeping animals away from transmission sites will avoid the zoonotic transmission for this disease, and especially for areas that are endemic for Japonica that we have not talked much about, which tends to be more common between both domestic animals and humans. And the other strategy is case management. Treat the animals where animals are affected. You know, so for bovine schistosomiasis, for example, that will affect cattle and so on. And then treatment with the praziquantel on a case-by-case, you know, individualized basis. And this is where, as we mentioned before, strengthening the health systems comes in. People need to be able to go to the dispensary, the frontline health facility, whatever that is, and be able to receive a diagnosis and receive treatment. And then there is the education, behavioral change, self-care, and so on. So we have to tie all of these all the time with education. People and communities need to know what's going on. What do they need to do? What's their participation? How they are affected? How do they seek help and support?
Yes. Can you actually can people get schistosomiasis from eating meat of a cow that is infected, that has bovine schistosomiasis? And you mentioned also that there are different kinds of snails, and that you have to be able to recognize which ones are the vector for this parasite. I mean, do they have like a distinct feature, a particular color? I have no idea what, how do you distinguish? Is it very easy to do?
Yeah, very good question there. Very good question. So the main mode of transmission, you have to be standing in the water, which has these infected snails, which are then passing through the part of the life cycle, the saccharia that comes from the snail, that then goes through your skin. So that's the only way you get schistosomiasis, not through infected meat. If you take undercooked meat, for example, from a pig, you would be getting, you could easily get teniasis, Taenia solium, which causes teniasis, or the tapeworm, which is another kind of worm that we also try to control in countries. But for schistosomiasis, it is the water bodies, the poor sanitation around the water bodies, and people get infected when they stand in the water. So women washing clothes, men who are fishing, children playing in the water. That is how this happens. And the longer people are in the water, the higher the burden of the disease, because it depends on the number of the tiny little worms, the saccharia, that go through your skin.
Okay, no, that's clear. That's clear. So really, it's the water that's the main, sort of medium there of transmission. So what is usually missing then in the way countries are dealing with it? What is the most common thing that a lot of countries that are still maybe finding this a challenge to bring it under control? What do they have in common?
What we have in common in terms of not achieving the targets for schistosomiasis elimination is really just ensuring these strategies that we just talked about are in place and fully scaled up. Okay, so we focused a lot in the past 10 years on preventive chemotherapy, ensuring that we reach everyone that needs the medicine treatment, the medicine to cure the infection that they already have. Okay, and then the rest of the strategies is to ensure that they don't get reinfected, because we have to treat every year as long as the transmission and the poor sanitation continues and so on. So if we treat people and if we can ensure that then they don't get reinfected by having in place all of these other strategies, the WASH, the One Health, and strengthen the health systems where people can seek treatment as they need, then we can begin to bring the burdens down and to reach our targets. So it's all these interventions that we have to keep working on getting there. But of course, then the countries need support in provision of easy to use point of care diagnostics. The diagnostics that we have in place now need experts that come to communities to do the mapping and so on, and not as easily used at the frontline health facilities where people can just walk in and get a quick test and know that they have the infection and get treatment. So diagnostics. At the same time, also the availability of medicines is a limitation. For now, we have one a big donation that is only targeting school-age children. So we don't have largely donated medicines that are available for adults, for example. So we've focused, many countries have focused on treating in school-age children within schools, while a section of the population is left out. the children that are not yet going to school tend to be left out. And the adults, in many cases, tend to be left out, which means the transmission continues because you have a section of the population that is not yet treated, and they continue to pass on to contribute to the transmission of the disease if they're still exposed to the water bodies. And so, countries going out of the way to have to commit to more resources to be able to purchase medicines for populations that are left behind as well. As we do our part in WHO in supporting research for a better medicines for preschool-age children, pediatric formulation, for example, which we hope will be available very soon through the Pediatric Praziquantal Consortium that WHO is supporting. And so these are some of the challenges that, are sort of limitations, but we have all the partnerships in place that are working to overcome these challenges and ensure that countries have access to all of the support that they need, as they also commit to availing domestic resources as feasible as possible. Yeah.
So it sounds like this is really about not leaving anyone behind, because every time you leave out a group, it means that the cycle of transmission is, continues to go on, and you're not able to break that. So being able to reach everyone sounds like a very, very critical piece. Now, if you mentioned how limited the available diagnostics are, because they're not readily usable or very amenable to ease of use at the point of care in the community health facilities, where a lot of these problems are happening, where they need to be detected. So is there a point of care rapid diagnostic that is already in clinical trials, or that you anticipate will come out soon, to be able to help your push to get to everybody, to make sure you're able to pick up the cases rapidly and reach everybody as effectively as possible?
There are a number that are still undergoing research, and WHO has also provided the guidelines for how these should be best fit for use in the field, for researchers to follow. So we're hoping to have these in place soon. We have, of course, in the past, as you may have had in place, the circulating anodic antigen, the CCA, that has been in use from an interim guidance that we provided to countries, especially in areas where the disease is very low and it's not easy to pick using the microscopic methods. So we're looking to research improving on these. There are actually point of care diagnostics that are in the pipeline, and we're hoping that in a year or a couple of years, we will have at least one or two in place that we can scale up at community levels. The diagnostics that we have in place now are labor intensive. They require experts and microscopes, lots of resources to the field, which are quite, quite expensive to sustain. And so we are, of course, looking forward to this rapid kind of care diagnostics. And we have as well research in the pipeline to also improve on the microscopic methods that we have, having those automated and such that they're not relying on objectivity of the technician or the training level of the technician. And so with our support and working together with all of the scientific groups and our WHO collaborating centers, we hope that we can avail these public goods to the community in the coming year.
Absolutely. They sound complex, not just expensive, but also very complex and demanding in terms of expertise. You mentioned a lot praziquantel when you're talking about treatment. To talk to us a little bit more about the range of treatment, the treatment options that are available. Do we have any more options besides praziquantel? Do we have options for you mentioned a clinical trial or something for children in preschool going age, and of course you are talking about a lot of your mass drug administration preventive interventions targeting school age children. What about grown-ups? What are the options that are available in terms of tools that communities are able to use, and how accessible are those tools to communities?
Yes, that's a very good question, because we have over-reliance on praziquantel, and the danger here is if resistance to this medicine could develop. Luckily, so far we have not seen any validated reports of resistance to this drug in the communities where we've used it, although there has been some pointers in laboratory reports and so on. But we have this one drug, praziquantel, that we are relying on at the moment, and we hope that research could avail more of treatment options. And so the formulation that's available comes in a big tablet, and we give it based on weight or height. And so someone will get a number of tablets all the way up to 4, depending on their weight or height. Mostly we use height because it's difficult to carry weighing scales to the field. And this tablet is very difficult for children to process. It's also bitter. Doesn't have a very good smell. So this is what the pediatric praziquantel consortium is working on, to make pediatric formulation that is sweet smelling, sweet tasting, and therefore is palatable with children, and preferably dissolving in the mouth, so that children can just chew it. So we're hoping that this will also be available soon. The clinical trials are being finalized and data is being reviewed, and we are looking into access and production issues. So that will be coming up. So this is the challenge we have also for the treatment options, and that's why we really need to strengthen all of these other strategies that ensure that we're also preventing and people are in safe environments where infections are limited as much as possible.
Yes, the point you make about the medications being child friendly, it's a particularly important one. I remember my daughter having to take an antibiotic once, and there wasn't a suitable formulation, for a child, and trying to crush the thing, hide it in yogurt, giving it to her and throwing it all up right away. It's quite a big challenge, I think, when you don't have medications.
And that's that's what we still recommend at the moment, while we don't have a pediatric formulation available. So individual case management for children under 2, for example, you have to crush it, get the appropriate dosage for the child, break it into the piece that the child requires, crush it, place it in some kind of food that the child is familiar with, and sweeten it if possible. Yeah.
Yes, no, that's it's quite a big challenge. So those are some of the shortcomings that you are having to deal with, having suitable formulations for children, for different age groups, and having treatment options. Because what happens if you start to see a lot of resistance in praziquantel? What would be the plan?
Oh, yeah, that would be very costly when we don't have an option to fall back on. And so we are looking forward to having a lot of research in this area as well, for other treatment options to be available. Luckily, we haven't seen much indicators in this direction, and what we have in place is surveillance for the efficacy of the medication of that we use, the anti-emetics. So we have these protocols in countries, and when they conduct mass treatments, then they also have to evaluate the efficacy of these medicines and report to us. So far, we haven't seen reports that indicate that we have resistance to this medicine. And so we are banking on it for the coming many years, while we also encourage research into options.
Fingers crossed we have a second alternative before we start to see that. Now, in terms of then access, you mentioned that there were gaps earlier on in our conversation. I mean, how big are the gaps in access, in availability, and how are you, or as WHO, working with governments to make sure that those gaps are closed?
Yeah, very good question there. The gaps remain because countries are yet to put in resources to purchase their own medicines. And now we are at the beginning of last year and concluding in this year, supporting the countries to finalize their third generation master plans. We are requiring in these master plans to have very strong components in domestic support for medicines, for activities, have these master plans taken through the cycles that are necessary in these countries for budgeting and discussed there, and provisions for budgets made so that your adults where medicine donation is not available can be budgeted for in those government budget decision cycles and included in these NTD master plans. So that's ongoing at the moment to address these gaps. I mean, we have countries like South Africa or Kenya, and where praziquantel is also manufactured locally. There are licenses to manufacture this locally. So we also hope that governments will also take advantage of the availability of these local manufacturing and be able to ride on that to provide medicines to their populations. So we do not yet have a further donation outside of what we have for school-age children. And so then this is an area where governments will need to really step up.
Yes, you touched on my next question, which was really about sustainability of production and access to those treatments, because my biggest worry is what happens if the shareholders of these companies that are currently making the one treatment that we rely on turn around and say, you know what, this is really not something we want to continue anymore. Like, we wake up the next day, how do we make sure that we have sustainable access? Can you just elaborate a little bit more then about the initiatives that are going on around local production, if that's something you're able to discuss?
Yeah, you just touched on a very important point there, and that is the risk of support not being available, because there are various dynamics around the world. COVID-19, for example, came and taught us quite a number of lessons. And in the last 1 year, we actually did have some huge donors that were supporting NTD programs in Africa pulling out, for their own domestic reasons, and so this was a wake-up call to us in the region that some of the reliance that we've had on outside support could be pulled out anytime, because dynamics do change. And so we have this, the two examples that I just gave, and I think what would be needed there would be starting with some of these few examples that we have in place, like I just mentioned, South Africa, Kenya, governments and ministries of health looking into how do we tap into this, how do we support it. I wouldn't say it's discussions that are going on now, but I would expect that in the support that we are providing for the NTD master plan development, and them looking into what are our what are the local opportunities for us accessing more medicines for our populations, that these are some of the areas that they will look at.
Yes, no, very, very important. Now, just to conclude our conversation, what is your call to action in terms of, what you would like to see going forward? Maybe just talk to us about 3 actions that you'd like to see, that you think, what, if we can achieve these 3, they will take us a long way towards elimination.
Yeah, excellent. The first one, the one that I would, really place at the very top is data. Data. We need evidence base for the activities that we do. We cannot achieve much unless we have data. And so I would call countries to commit to mapping of schistosomiasis at community levels. We need granular data. We need to know what's happening in every community in order to make decisions for that community. In the past, we've had very inadequate data, and so we put this data together and make a decision for a region, a district. For example, say, well, you need to treat the people in that area, but you don't have adequate information. And so we need data. It may be costly to do mapping, but then once you have the data, then you can expect that your decisions will be better informed, and you will be able to use your resources more efficiently. So that would be the number one, and I could actually just make it the only one because it is so important. But then the others, we've already touched on those, and it's more investments by governments, and then integration of schistosomiasis into the primary healthcare. Have medicines available at the frontline health facilities at all times, diagnostics in place as much as possible, and health managers aware of the transmission in their settings and participating actively in the prevention and control. So, we already talked about this at length, but this is part of the sustainability. We've had disease activities standing, as silos on their own, as an activity that comes to the community once a year. We want it to be something that activities can access treatments throughout the year. That comes with integration into the primary healthcare. And so, just in conclusion, then we are looking forward to just deepening all these engagements with all of these stakeholders that I've talked about at all levels, and most importantly, the communities.
Yes, so getting better data so that you can be more targeted and understand your burden of disease better, so that you can plan better, invest more in prevention, in treatment, so that we can break the chain of transmission, and better collaboration between all of the partners that are involved in this. Dr. Pauline Mwinzi, the Technical Officer for Neglected Tropical Diseases at the World Health Organization Regional Office for Africa in Congo-Brazzaville. Thank you so much for coming on to Let's Talk About Health in Africa. It's been a great pleasure to have you on.
Thank you for the opportunity, and thank you for having me.